Good morning, everybody. It's Cindy Gillum, your host of Coffee with Clinicians. I'm here with the esteemed Dr. Larsen from Weill Cornell up in New York City. Dr. Larsen, why don't you tell everybody what your background is and what you do up there in New York?
Well, I'm a podiatrist that has a practice that really has two components to it. I have really a specified wound care component of the practice and a regular podiatry practice as well, where we do everything podiatric related of the foot and ankle, including wounds. So I really have two different practices rolled into one. Part of that's in Long Island and part of that's in New York City, as you mentioned, at New York Presbyterian, where I work at a wound care center there.
Awesome. And so you see the worst of the worst. I know because I've seen pictures of some of your wounds.
Yeah.
So when this got presented to you, tell me what your initial response to the therapy was, and two-part question. What when you used that product, did it verify what you believed, or did it change your belief in what the therapy does?
So I'll start by saying that I've never really been a user of oxygen therapy, whether it be topical, HBO, or now the CDO. And I was always a little apprehensive about it. And I guess probably one of the reasons was HBO is just, it's a lot of work. It's a lot of work for the patient. It's a lot of work for everybody in order to get the patient there. And the compliance rate really isn't that great. So when I first heard of EO2 and CDO therapy, I was a little apprehensive about it. But you know, I think with wounds, you have to try everything. And so I tried it and I saw positive results. And at this point now, it's really become my standard bandage, believe it or not, when I see a wound. So it's become part of my standard of care. And it's integral part of my wound practice.
And what kind of wounds do you see that you determine is fit for CDO therapy, especially as that standard of care when you say that?
Yeah, so I see all kinds of wounds. I see traumatic wounds. I see venous stasis wounds, arterial wounds, all vascular types of wounds, diabetic foot wounds. I use it for all of them. And, you know, part of the reason I do is what I just mentioned, and also because it's painless. And I think bandages and devices, for example, negative pressure wound therapy, which I'm a big proponent of, can be painful on patients, and sometimes their use is limited, especially in patients who are not neuropathic. So it really, I use it in all types of wounds.
And talk to me about the team that you work with. You've recently changed your protocols to incorporate this as your standard of care. So what's been the response from other physicians that you work with, you know, upon taking on this big change within your practice?
Yeah, so that's a good question. I guess me and my patients were the guinea pigs, and you know, I've conveyed my successful use of the bandage, I would say, to my partners and associates, and they've started to incorporate it too as part of their initial bandage when treating wounds.
And it's interesting because I've seen there are several doctors. I've been at excuse me, this for about 3 years, and there's several doctors that really stand out with their outcomes, and you happen to be one of those. Because I've seen your cases, I've seen your work. Give me some pearls of wisdom that you think contribute to the success rate that you have in healing these patients. And when I say healing, you're bringing these all the way to full closure.
Well, we hope to. You know, it's anybody who does wounds know that we don't always close wounds 100% of the time. And I think that if we can close half of these wounds, that's pretty successful. whether they lead to a minor or a major amputation. What I've really thought about the bandage is that it's just an adjunct for me. So everything I use is an adjunct in wounds. I think that you really, I went to a lecture one time at a symposium, and I was speaking and I was listening to a doc from Rhode Island, I forget his name, and he puts up a big toolbox at the beginning of his lecture. And I think it's a great analogy, because I think with wounds, you have to have everything in the toolbox, and then you have to figure out what's best for each patient. So for me, it's an adjunct. I use it with, the traditional standard of care of off-weighting, debriding, evaluating for infection and vascular status. And then any other thing that may be needed: skin substitutes, negative pressure wound therapy, surgical offloading, remodeling or reconstruction of the foot, appropriate shoe gear and bracing, and so forth. So it's in there now. It's part of my toolbox, I would say, to take something from another doc. And that's really where I think it really fits. I don't think that any one thing heals wounds, and anybody that does wounds knows that. So it's just an integral part of my practice at this point.
I think you hit on it, because this product has made me, I think, a better clinician, because there is the cliche in wound care that, you treat the whole patient, not just the hole in the patient. You're absolutely right. There's no cookie cutter, one size fits all. It's understanding the complexities of the puzzle that's presented to you and tackling all of those pieces. And this is just one of those pieces, and it works well in conjunction with other, tools in our armamentarium. And you can't discount, really good debridement, really good offloading, patient compliance, and exudate management, all of these things that, just are not going to be solved with one product.
Yeah, and I like the exudate management of the bandage too, and the fact that you could use alginate underneath there too when needed, and I still use my wound care products. I still use my creams, my Santal, my Regranix if I need to, or or even medical grade honey. So I don't use it in thick layers, but I do use it, and those products do absorb, and the oxygen does diffuse through into the wound, even with those products. So I'm not afraid to use it in conjunction with things that I already have in place.
Now, you brought up an interesting point too. So you do use creams. What do you in particular use? We know that if we get a lot of exudate, that means the therapy is working, because it's waking up the reactive oxygen species within that wound. What do you use on the peri wound to protect that good intact skin?
So I'll use an alginate at times to protect the skin. I'm not a big user of betadine, but sometimes I will paint some at the wound periphery to help dry it out. I've used gentian violet in the past for things like that. I'm not a big fan of that either, just because I don't like the purple look about it. But these things do work. The alginate I've been happy with. I also, when the wounds are draining a lot, we tend to lower the diffusion of oxygen through the wound. And we also do more frequent bandage changes. So those things in conjunction with some local care to the skin can be very helpful.
That's awesome. And I think that's one thing that sets us apart, is the ability to adjust that flow rate to either manage exudate or manage pain within the patient's wound. And it's been a pretty valuable tool for us. Where do you see the need for research is within CDO therapy?
So I think that it should become part of standard of care. I mean, I think that the research could lead down a couple of different avenues. I think that when you talk about Medicare and you talk about approval and reimbursement and standard of care type therapy. I think they're looking at efficacy, and they're looking at compliance, and they're looking at cost. So I think if there can be research in those areas to show those components and how CDO therapy can lower cost, increase efficacy, increase compliance, I think that'll be a positive thing. I also think that for me personally, after reading a lot of the literature and going to learning initiatives, I would say there seems to be this secondary reduction in pain of patients who use this, and we've talked about this already. So I'm interested to see this bandage actually become a routine bandage in elective foot and ankle surgery, and see if that can reduce the need for opioid use. We're working on something right now, starting to get a little proposal together, and I'm very interested to see if indeed that can reduce the need of opioid use in an acute postoperative care setting for elective foot and ankle surgery. So I think that maybe that's more of a want for research for me, not necessarily a need. But the opioid crisis is huge. It still exists, and I think that anything we can do to potentially reduce that can be helpful.
And I think in the end that saves, taxpayer dollars as well with regards to healthcare, as well as, tackle a large problem that the country has.
Yep. Yeah.
In closing, what would you say to Medicare to ask for CDO to make it more accessible to patients by granting that payable code with respect to your experience?
I would say that if you look at cost, if you look at efficacy, and if you look at patient compliance, like mentioned before, and you can show them, CMS, that there is a reduction in cost, that there increase in efficacy, and that there's an increase in compliance, that's what you need to show them. And I think that look, I don't work for Medicare, I don't work for CMS, but we all deal with them on a regular basis, and I think that those are the things that they look for. Wounds, diabetic foot wounds especially, is a huge cost in this country. And there's amputations that occur by the second. And we know that there's a lot of literature on that. And if we can reduce those things and reduce cost, and I think that that's what they want to see. When you compare it to other therapies, oxygen therapies, you can be mobile with this. It's light, it's easy to use. You don't need visiting nurse service. A patient can change a bandage at home. It's very easy. You don't need to be transported to a facility to have hyperbaric oxygen. And there's costs associated with all these things. There's compliance associated with all of these things. So I think, showing all of these aims, it's quite possible they may give a payable code at some point.
Well, I really appreciate your insight and I look forward to seeing the studies come out of your office and over there.
We're working on them.
And I look forward to working with you more in the future. So I really appreciate your time today, and hopefully we'll talk again soon. I'm sure we will.
Okay, thank you. It was nice talking to you.
You too.